Recording is on now. We are going to start. So good morning. On behalf of IAP Delhi and IAP Delhi branch, I welcome all the delegates and all the faculty members. We have Dr. Gauri Kapoor ma'am today with us. She is the medical director at Rajiv Gandhi Cancer Institute and Research Center at Mithiba, and she is director of pediatric hematology and oncology at Rajiv Gandhi Cancer Institute. She is the past chairperson of the PHO chapter of IAP, and she is on the board of directors of INPHOG. And her special areas of interest are molecular aspects of all childhood cancer survivorship. So she'll be speaking about the how not to miss cancers in children. So I request ma'am to please share the screen and start with the presentation. Thank you.
Good morning, everyone. And thank you, Dr. Ajay, for the kind introduction. Thank you, Dr. Ajay and Dr. Vipul, Dr. Jagdish Chandra, Delhi IAP, East Delhi branch, for inviting me to this very important certificate course in pediatric hematology oncology. So good morning to all the participants, all pediatricians, I'm sure. And today is a very important topic in childhood cancer, as you will see as we proceed in this presentation. It is important for the pediatrician to not miss the diagnosis of cancer in children. So today's agenda point is we will talk initially about the burden of cancer, the outcome of cancer in children, what this WHO global initiative is, how not to miss the diagnosis of childhood cancer, especially when shall we suspect cancer, and intermingled in this presentation will be case scenarios. So what is the burden of disease? Globally, almost 1,000 children are diagnosed with cancer every day. So considering other pediatric conditions, it seems like a small number. When we compare cancer in children as a percentage of all new cancers in children and adults, they barely constitute 1.4% of the total burden. So if we look at this statistic, which is based on the GBD data, also called Global Burden of Disease Study, this is the Institute for Health Metrics and Evaluation, we will see that the absolute numbers in 2017 were estimated, I'm saying again, estimated to be about 416,500. The age standardized incidence rate, 162 per 100,000 person years. The absolute mortality, 142,300. And the age standardized mortality, 55 per 100,000. The incidence to mortality ratio being 2.9, that means for every 2.9 or 3 children, 1 will die. So moving on, we can also see here that out of the 416,000 cases, approximately 50,000 occur in India each year. So nearly half of all childhood cancers, unfortunately, are not being diagnosed globally. And this is based on a modeling study by the Harvard School of Public Health. This study found that in 2015, of the nearly 400,000 cases, 224,000 were only diagnosed. So half of them were not diagnosed. And it is also estimated, researchers estimate, that between 2015 and 2030, if our current health systems around the world do not improve, 43% of these patients projected will not survive, which is a tremendous number. 2.9 million out of 6.7 million will be missed. We will not diagnose them. So if we don't diagnose them, they will not survive because it's a potentially fatal disease. What about the outcome? This data is a Western data. It's based on the SEER data. And actually it's the survival of 0 to 14-year-old children with cancer. And if you see here, over the decades, from the 70s to the 80s to the 90s, till early 2000, steadily there is progress in outcome. Survivals, if you see here, this is the Kaplan-Meier survival curve. The survival in the West, even in 2001, was more than 80%. So children in the West are 80% likely to survive if they get diagnosed with cancer and are properly treated, which means modern treatment can cure most of the children. However, if we look at this data, it's the data from ICMR. It is the National Population and Hospital-Based Registry data from India. And we compare it with that from Europe and USA. We will see here, this is the Bangalore registry, the first column, Chennai registry, Mumbai registry, then we have Europe, and then we have the USA. We see leukemia lymphomas in the early, this data is a little old, but it was 35 to 39%. Even for leukemias, which are supposed to be curable in India. And if you look at the bottom line, all cancers, that is also 37%, while in the West, it is nearly 75 to 70. This data is old, but I'm just giving you a comparison that we have a long way to go. And also, they are not diagnosed. If we don't diagnose, we will not treat. So if we summarize, now it is now well established that for children in high-income countries, more than 80% will survive. While in low middle-income countries, where 80% of childhood cancer patients live, the survival is 20 to 40%. Hence, this global initiative for childhood cancer was established with the joint goal of increasing survival rate of children with cancer globally to at least 60% by 2030, while reducing their suffering and improving their quality of life. And it is believed that with this effort, if it is successful, almost 1 million lives can be saved. So there is now a global initiative also for childhood cancer, as we will see in the slides. So how do we assess? We are saying that 1.4% of all cancers are pediatric cancers. So how do we assess the burden of childhood cancer on the community then? So clearly there is this metric called disability adjusted life years. And what is disability adjusted life years? It is based on two factors: number of years of life lost and number of years of life lived, years lived with disability. So if a child with cancer is diagnosed at the age of 2 and he dies, then they will count number of years average he would have lived, say, for 65 or 70 years. So on the basis of that, years of life lost plus how many years the child lives with disability. On the basis of this, a disability adjusted life year metric is calculated. And what does it show? It shows that if we have all the cancers listed, then in the low middle income countries, it ranks 6. So these 20 odd cancers are there in adult and children, and pediatric cancers, based on this burden, the disability, it is ranked 6, which is pretty high. It is quite low in the high income countries. It's something like 22, but in countries like India, it is almost 6. Secondly, if we look at all the childhood illnesses, and then we rank it, and we find that in low middle income countries, childhood cancer is ranked 9. So even though we have respiratory diseases, diarrheal diseases, malaria, nutritional deficiency, HIV, all of which come above it, but there are a host of other diseases which are less burdensome as compared to childhood cancer. It is 9 amongst all childhood conditions in LMIC. In the West, it is much higher. It is number 3 or number 4. So what is this global initiative? As I said, it was established in 2018, and we hope that we will have improved outcomes of at least 60% around the globe, all over the world. And if successful, the lives of 1 million children with cancer can be saved. So we are all part of this initiative. So since the cancer is curable, once we diagnose it early, we don't miss it and treat it properly, we will have good outcomes for our children in India. So don't miss the diagnosis. Quickly, just again reiterating that as per Indian data based from ICMR, from the Population-Based Cancer Registry, childhood cancers constitute, you can see, anywhere between 1.6 to 4.8% of all cancers. So clearly, it is rare. So why do we miss the diagnosis? Why are we so concerned about it? Very clearly, it is a rare disease. Secondly, the signs, there are no unique signs and symptoms of cancer in children. The signs are similar to symptoms of common childhood injuries or illnesses. And frankly, in a review, if we see this review from Children's Hospital from the University of Rochester, which was done on 354 pediatric patient records, it was found that the initial diagnosis was incorrect in 52% of the cases. So look at this example. A child vomits, has abdominal pain or decreased appetite or has a fever or fatigue. Initial diagnosis will obviously be a benign condition or something like a stomach flu. So the symptoms often mimic common illnesses and therefore we miss it. So it is important to know what are the red flags in these symptoms. So the delay, because there are no telltale signs, but also because there is a reluctance to entertain diagnosis. And having a high index of suspicion will definitely help early diagnosis. Delays, as we know, lead to high complication rate and poor outcome. So quickly coming on then, what are the various types of cancers in children? How do we group them? So we group them as hematological cancers, which are the leukemias, as you well know, acute lymphoblastic leukemia and acute myeloid leukemia. Then we have the lymphomas, the Hodgkin's and the non-Hodgkin's lymphomas. The second group, we call them the solid tumors. So also the solid tumors, we call them extracranial solid tumors and the CNS tumors. Amongst the extracranial, this whole group is there, which occurs in children less than 5 years. Wilms tumor, neuroblastoma, rhabdomyosarcoma, retinoplastoma, hepatoblastoma. These, as you can very well see, are based on the organ of origin, the Wilms coming from the kidney, neuroblastoma most commonly from the adrenal or the sympathetic ganglion, rhabdomyosarcoma from muscle, retino from the retina, and hepatoblastoma from the liver. Then the adolescents have bone and soft tissue sarcomas and germ cell tumors. And then we have the CNS tumors, the brain and the spinal tumors. So how frequent are these relatively? So if we look at the frequency distribution, as you well know, the leukemias constitute a quarter of all the cancers in children. So 25%, of which 75% are actually the ALLs. This is international distribution. The Hodgkin's and the non-Hodgkin's lymphomas together constitute about 15%, and the brain and the spine tumors, 20%. So you can see leukemia, lymphoma, and brain tumor. These are the three largest groups, and all the rest constitute 3 to 5% of all the other tumors. So the percentage of the others are fewer. But if you look at the frequency, this is the distribution of data from the hospital-based registry in India. We will see that in India, 43% of the cancers that are picked up are the leukemias. And why is it so? It is so because the others get missed. They don't get diagnosed. They may not get reported. They don't get treated. So many of the non-leukemia cases get missed because there is no other reason. A lot of research has also gone here that leukemias reporting in India and being diagnosed is more amongst the children as compared to the other cancers which don't get diagnosed at all. So also we should remember that adult cancers are very different from pediatric cancers. So what is different about pediatric cancers? Not only are they rare, but it is important to remember that there is no environmental exposure implicated in more than 90%. While in adults, it is the smoking, it is the pan parag, it is the chewing of tobacco, it is HIV, it is hepatitis B, and many other such exposures which cause cancer. You can see HPV for cervical cancer, but in children, there is no known cause in more than 90% of the cases. The other very important things to remember are these are high grade, they are very chemosensitive, and they have high cure rates, unlike the adult cancers. So what are the common symptoms? 85% of childhood cancers will present with symptoms like fever, PUO, pallor, pain, lymphadenopathy, mass, purpura, persistent headache, or change in gait or vision. So how do we group them? So mostly it has been seen that 80% of, I said, childhood cancers are high grade, and 80% of childhood cancers are actually disseminated at the time of diagnosis. So many times they have constitutional symptoms as well. So if we group them, we can see mostly the leukemias and lymphomas have symptoms and signs related to marrow involvement. So the 3 cell lines are involved, either both 2, 1, or all 3 may be involved, and you may see things like pallor, fever, or bleeding. Then there is involvement of extramedullary lymphoid organs like lymph node, liver, spleen. So we can have lymphadenopathy, hepatosplenomegaly. Then the solid tumors often present with masses, abdominal distension, abdominal mass, mediastinal mass, neck mass, orbital mass, or scrotal mass, masses anywhere, often painless initially. Then they can have symptoms related to their infiltration or pressure on surrounding organs or tissues, which may lead to urinary frequency, constipation, pain, headache, vomiting, change in gait, etc. So we will come one by one to these frequent symptoms which are seen and see what are the red flag signs in these. What are the red flag signs which can make us suspect that this is cancer in a child, and how we may not miss the diagnosis. So prolonged fever. We know that fever is a common constitutional symptom. It is, most infections will present with fever. It's a very non-specific sign. A clue, however, a non-specific clue, and mostly associated with infections. But if the fever is prolonged, it is unexplained, there are no other causes of the fever you can't find, it persists beyond 2 weeks, it is not responding to your usual treatment. In the absence of an infective basis, this type of PO must arouse suspicion in the mind of the pediatrician of a neoplastic process. And we need a thorough history and examination. And the last 2 points I will say, that look for associated signs and symptoms. And the first investigation we advise is a complete blood count and a peripheral smear examination. Coming back to thorough history and examination, a child who has a prolonged fever, more than 2 weeks, 3 weeks, he will come back to you in your OPD multiple times. And at every visit, it is very critical that we once again take a history for any new symptoms and thoroughly examine the child, because a spleen which was not there in the first week may appear in the second or the third week. Skin petechiae which was not there initially may come. Lymph nodes which were not there initially may come up. So we should not feel, "Arey, 2 दिन पहले तो देखा था, and अब क्या देखना है?" So we must examine the child on the couch at every visit if the fever is not responding and it is persisting. The associated signs and symptoms that I told you, they actually include refractory anemia, generalized lymphadenopathy, hepatosplenomegaly, bone joint pains, and bleeding. And in the complete blood count and peripheral smear, we could see the red flags would be presence of pancytopenia, the presence of high white count, lymphocytosis, and the presence of blast cells in the bone, in the peripheral blood. So I will now show you a few case scenarios which could give you an idea how these children present and how and when can I suspect, so that I don't miss an early diagnosis. So typically a 3-year-old boy, fever off and on, it goes away, comes back 15 or 20 days. He's listless, he doesn't want to play, he doesn't want to stand. And probably he has body aches, but he doesn't complain. Children usually don't talk about body aches. So they will just be cranky or irritable. So he looks pale, he is irritable, doesn't want to be examined, doesn't want to stand on the couch, has small neck nodes, and a mild hepatosplenomegaly. Typically, one would think that it is either depending on the season, whether it's a respiratory viral infection or it's an enteric fever, or depending malaria, dengue, any such thing, and we would investigate accordingly. But when the fever is not responding, we need to do a complete blood count. And here you will see that often you may see that there is a normocytic normochromic anemia. The WBC count is 17,000. But the important thing is that there is lymphocytosis. When we see the lymphocytosis, it is critical that we also look at the neutrophils. Often in viral infection, neutrophils will not be 10 or 12 or 8%. They will be something like 30%. So this is a red flag. This is clearly a red flag. You must call your pathologist and request them, or hematologist, whoever is looking at the CBC smears, that kindly look at the smear. And very often you will see that the pathologist will call you back that I'm seeing suspicious immature blast-like cells in the smear. So it is not difficult for a hematologist. So if a hematologist has a lot of work and if they're looking at lots of slides, they may miss it. But if you call them and they're giving attention, they will definitely not miss, because the activated lymphocytes, often seen in the virocytes that we say, sometimes can look like blast cells and they may just get missed. So that is important. So looking at the clinical scenarios, the leukemias often will present like this with fever, generalized lymph nodes and hepatosplenomegaly, or he may just have pallor and fatigue, pancytopenic, or he has the irritable child. They may also come with the older children, come with one or multiple joint swellings, and we will look at it again. So once again, I'm highlighting what are the peripheral smear findings: lymphocytosis, bicytopenia or pancytopenia, and presence of immature cells. One or all may be present. And these can give you a clue that it could be an acute leukemia or a marrow involvement. The 5 P's of leukemia, we call them pyrexia, pallor, pain, fatigue, and peripheral blood blasts. So this is important, and combination of these will give you a clue that you are dealing with something which is a little more problematic than just an enteric fever or a viral infection. So the next symptom that we will discuss is anemia. So when should we suspect that there is a problem here? When can we suspect? Anemia is very common. And as you know, in children less than 5 years, almost 67% are anemic. Adolescent girls also 2/3 are anemic. And 30% of adolescent boys are anemic. So anemia in our country is very widespread. But we should not get distracted by presence of microcytic hypochromic anemia in our patients. Anemia can coexist with leukemia, so don't forget that. Since anemia is so common, every other child will be anemic. So we should not get distracted that, oh, the smear has microcytic hypochromic anemia, it cannot be leukemia. So when are we worried about an anemia? If it is rapidly progressive in the absence of blood loss, if there is a repeated fall in hematocrit over days despite hematinics, or if there is a red cell transfusion required, we would be really worried. And then we would see if there are any of the associated signs and symptoms that I mentioned in one of my previous slides, that is the lymphadenopathy, bleeding, abdominal mass, bone pains, joint pains, etc. So a history, of course, your dietary history, whether they have, how long has the problem been there, or look at all the old reports, and then look at the complete blood count, see if a good smear examination has been done. You may also have a leukemia occurring in a normocytic. Normally, if a person is not anemic baseline, leukemia would be associated with a normocytic normochromic anemia. But with such a high prevalence of microcytic anemia in our country, it can often coexist. So I have just put these 3 slides here. The one on the left is normocytic normochromic anemia, and you can see a normal neutrophil along with it. The right side, you are seeing a microcytic hypochromic anemia, teardrop cells, and a normal lymphocyte. And the slide below is that of a patient with leukemia with a normocytic normochromic anemia, and the arrows are showing you the blasts. How do we recognize the blasts? They are 2 to 3 times the size of the RBCs, and you can see almost the entire cell is filled up with the chromatin. There's a high nuclear chromatin ratio, open chromatin. Sometimes you can even see the nucleolus. So ask your pathologist if you're worried to re-examine the smear. Another important manifestation could be bone and joint pains. Frequently manifested in patients with leukemia. When a neuroblastoma has metastatic bone disease or bone marrow disease, these patients may also have bone pains. And any other cancer metastatic to bone or bone marrow would also have these symptoms. However, in patients of leukemia, the interesting thing is a clear-cut arthritis may also occur in 10 to 15%. So I have a few more slides in which I will tell you a little bit more about it. So anemia, leukopenia, pancytopenia in a child with arthritis should prompt further evaluation. And if steroids are contemplated, the clinician may consider a bone marrow examination. So leukemia does come in the differential diagnosis of JIA or juvenile idiopathic arthritis. So ALL can mimic JIA and JIA can mimic leukemia. So the various studies have been done, and mostly we feel that it has been observed that in ALL, the pain is usually more at night, while the JIA patients will have morning stiffness. Peripheral blood would find neutrophilia in JIA, while we will have lymphocytosis in children with leukemia. So a careful history and examination in the patients with bone and joint pains is very important. Often in leukemia, the disease is multi-articular, multiple joints. There is bone pain also along with joint pain. The pain is often present even at rest, more at night, while the JIA would have morning stiffness. Look for associated signs and symptoms. And again, in the CBC, look for lymphocytosis, look for low neutrophils. This is important. And if you look at this CBC here, you may also say the platelet is borderline low, patient is also anemic. So there are, like I said, no very characteristic. If we want to diagnose early, we have to pick up these early clues. Otherwise, we may miss it, and these patients may then have more advanced disease at the time they get actually diagnosed. So this is the other conditions which can be mimicked. So there are benign non-malignant conditions. So leukemia patients may mimic JIA as we saw. Also viral infections like infectious mononucleosis. And I may tell you, infectious mononucleosis often presents or mimics lymphoma patients. They have these large neck nodes. I recently saw one in my OPD about 2 weeks ago, 2-3 centimeter large nodes. And the peripheral smear shows lymphocytosis with activated lymphocytes. Sometimes it is difficult to exclude leukemia in these patients. The child had EBV, IgM, and IgG positive. And in fact, next week when they came for follow-up, the lymph node was still present, And the sister had also similar lymph nodes. These may take 3, 4, or 5 weeks to regress completely. So I think it's really important to see these children frequently and to also explain to the family that we cannot exclude it. We must come again to the OPD, follow up till the lymph nodes completely resolve. Sometimes otherwise we can miss a leukemia. Then we have aplastic anemia, where all the 3 cell lines are diminished, and leukemias about 5 to 10% may present that way. And sometimes the children may have received alternative medicine, Ayurvedic or other medicines, which can also suppress the marrow and lead to a picture like aplastic anemia. ITP is, I think, very well discussed by everybody. And we know that if we want to give steroids, that everything is characteristic. We don't have to do a marrow. But if there are atypical signs, we must do a marrow before giving steroids. But if it is very clear cut, we don't have to do. If the smear has been seen by a trained hematologist, we are good. But if we are in a periphery and we don't have a good hematologist, all the reports are coming through the Coulter machine, no pathologist or hematologist is seeing the slide, I will say before giving steroids, if there is some other doubt in your mind, please do the bone marrow so that you don't miss leukemia. But a good smear can exclude. So that is important. Good peripheral smear examination is very important. So moving on to lymph nodes. So lymph nodes, as we know, they are very common. What is the definition of lymphadenopathy? It is a term that refers to lymph nodes that are abnormal in size, number, or consistency. Lymph nodes, as you know, may be palpable in healthy as well as sick children. They are not all palpable, and not all palpable nodes are pathological. So any good teaching, clinical teaching will tell you that examination of lymph nodes is an integral part of a good physical examination. They can be a clue to underlying systemic disease. However, because of its association with malignancy, there is a lot of parental anxiety associated with this. So it is a challenge for the pediatrician to correctly identify and recognize nodes as being pathological or non-pathological. And reassurance for non-pathological nodes is good to prevent unnecessary investigations. So in our clinical approach, we must definitely look at the age of the patient, size of the nodes, location, consistency, whether they are localized or generalized, duration, associated signs and symptoms. So one thing to remember, newborns do not have palpable lymph nodes. Okay, so this is important. If you are seeing a node in a newborn baby, you have to worry about it. You have to further investigate. Palpable nodes in neck, axilla, groin are common during childhood, and in the age group 3 to 5, these would often be there, 90% of cases, as it is the age of lymphoid hyperplasia. As a child moves around, goes into the environment, is exposed to various pathogens, this is the age of lymphoid hyperplasia. A third of normal children would have nodes palpable in the neck. Most often, these are benign. They are seen in the setting of viral illness, exposure to respiratory infections, etc. So when do we worry them? So to remember one thing, that lymphoma nodes are usually not pain. They are not painful. So painless nodes is a clue. Associated signs and symptoms are a clue. Having a high index of suspicion is important. So what are significant nodes then? Cervical nodes, axillary nodes more than 1 centimeter in children, inguinal nodes more than 15 millimeter. Then nodes at unusual sites, supraclavicular, epitrochlear, mediastinal, these warrant further investigation. Progressive nodes, progressively increasing in size and persisting for more than 4 weeks, again warrant further investigation. If a child has been started on ATT empirically and the nodes are increasing in size, once again, it warrants further investigation. So let's quickly do a few cases. 11-year-old girl, progressive neck swelling, weight loss so the swelling is there, gradually increasing for 1.5 years, weight loss for 2 months, and They have actually taken ATT, taken many antibiotic courses, done multiple FNACs, till they finally came to us. So you can see very well here that this is very advanced. There are bilateral large cervical lymph nodes, left being much larger. There's a conglomerate of nodes. There was no hepatosplenomegaly, there was no fever, and the CBC was perfectly normal. So multiple FNACs had been done, and they were showing presence of lymph monocytes, eosinophils, histiocytes. So it is important to remember that in suspected lymphoma, we would like to do biopsy. Why do we want to do a biopsy? We want to do a biopsy because in a child of lymphoma, especially Hodgkin lymphoma, 90% of the cells are benign cells, reactive cells, and the Reed-Sternberg cells are only present in 10%. So when we do FNAC, we can miss. Sorry. So it is important that if you clinically suspect, you should do a lymph node biopsy, not an FNAC. FNAC can help miss the diagnosis. And then the patient may come with these big large nodes, which is not good because by this time the stage may be more advanced. Coming to the next case, 3-year-old girl with left-sided neck swelling, also swelling around left eye, low-grade fever, fullness of leg, left supraclav node, and also the alert clinician noted ptosis and meiosis and Horner syndrome. CBC shows anemia, the rest was normal. So an X-ray showed left upper zone mass. So anybody has a clue what is this? So there's a Horner's, there's this haziness or there's a opacity in the left upper zone. So what could this be? And there's a Horner syndrome. So I don't have the lateral film, but the lateral film showed that this is a posterior mediastinal mass. So the posterior mediastinal mass is actually the sympathetic paravertebral sympathetic ganglion enlargement by the neuroblastoma. So clinical clues are important. So this child has actually presented with a supraclav mass, and that is actually a neuroblastoma involving the cervical sympathetic chain. And involvement of the cervical sympathetic chain has led to Horner syndrome, which is ptosis, meiosis, and anhidrosis on that side of the face. So this is very classical presentation seen in young children, and they often do well. It is often in infants with neuroblastoma of the cervical sympathetic has a very good outcome. A urinary VMA gives a clue. A biopsy or a bone marrow would also be required for staging, and treatment will depend on what is the stage of the disease. So neck masses, as you saw, could be benign, could be reactive, could be viral, could be tuberculosis, and could also be conditions like cystic hygroma. And of course, amongst the malignant conditions could be a leukemia, lymphoma, sarcoma, neuroblastoma, etc. In these pictures here, right on top, what you see, this child had a lymphoma, Hodgkin's. The little baby here, this is actually was a very advanced sarcoma. And this little boy here, you can see very well, he has generalized lymph nodes. You can see he's having breathing difficulty. He had fever, weight loss, and he was actually having ALL. So high index of suspicion and looking for the associated signs and symptoms will help you early diagnose your patients and not miss them. So in cases, how do we proceed with these patients with lymph node where we suspect there is a problem? When we suspect there's a problem, what do we do? When we suspect there is a problem, then we want to make sure, does this child have constitutional signs and symptoms, or it is just isolated lymph node enlargement? And then we look at the CBC. If the CBC is perfectly normal, we do lymph node biopsy, we don't do FNAC. If there are clues in the CBC or in the other symptoms in the child, then we will prefer to do, if we are suspecting leukemia, a bone marrow rather than a lymph node biopsy. So that is another thing. Presence of any CBC abnormalities, or if there are generalized nodes and I'm suspecting there is fever, bone pains, I will prefer to do a bone marrow. I will not like to do a lymph node biopsy. Many patients come to us with leukemia, which is diagnosed on lymph node biopsy. But if you carefully look at the CBC, you can easily tell that this patient need not have got a lymph node biopsy. We could have easily got the diagnosis by peripheral blood and bone marrow aspiration. So then coming on to how can the other solid tumors present? So they may present as masses. So the masses could be anywhere. Like I said, abdominal masses, pelvic masses, mediastinal masses, extremity, scrotal, orbital, and CNS. Depending on the patient's age, depending on what was the organ of origin and what is the site of the disease, we can have clue about what is happening to this patient and whether we should suspect cancer or is it a benign condition. Just we should remember that abdominal masses, so we will do one by one all the masses. Abdominal masses after 1 year of age are usually malignant. Solid abdominal, palpable, firm, solid abdominal mass is the commonest sign that would suggest a diagnosis of a malignant tumor. They frequently attain large sizes prior to detection, and the age is a valuable clue. Symptoms may also occur due to pressure on adjacent organs, on the bladder, on the bowel, etc. So young children less than 5 years, firstly, I will quickly say less than 1 year of age, we are not sure it is benign or malignant, more likely to be benign. Vascular malformations are the most common, often in the liver. So don't jump and call it a liver tumor till you are sure. Most likely something in the liver, get a proper ultrasound. And also don't jump and look at the AFP and say this is hepatoblastoma, because in infants, the alpha fetoprotein levels are high and gradually normalized by 10 months of age. So make sure you use the chart to know whether this AFP is abnormal or appropriate for age. Coming to malignant masses, we have different things happening in children less than 5 years and different tumors occurring in adolescents. So the Wilms, neuroblastoma, rhabdomyosarcoma all occur in less than 5 years, usually in 90% of the cases. Hepatoblastomas present usually about 1 year of age. Amongst the adolescents, the common tumors are germ cell of ovary in girls, lymphoma, abdominal, and PNET of the abdomen. And the first investigation is the ultrasound. And we always say, do not be in a hurry to biopsy, because when you biopsy, you can upstage the disease. So if it is a solid mass, the child is more than 1 year, it is better to refer further if your unit is not going to treat the patient, because doing a biopsy can upstage a curable cancer and make the treatment harder and more toxic. So just to show you pictorially, the first case here, abdominal masses, 1 to 4 years of age, arising from the kidney, there's this typical claw sign. So this heterogeneous mass is Wilms tumor. The second picture is showing you suprarenal. You can have neuroblastoma either in the paravertebral region or in the suprarenal or adrenal area. Then there may be midline lymph nodes. So midline mass, crossing midline, presence of calcification, and usually systemic symptoms. In Wilms tumor, usually child is playful. The only other thing may be hematuria. In neuroblastoma, usually patient may present with fever or bone pains. Unlike Wilms tumor, where child is playful and is not having any constitutional symptoms. Hepatoblastoma, usually this liver tumor you will see on CT, but importantly, they are usually 1 year of age. And when you do an AFP, it may be 50,000, 1 lakh, 2 lakhs, very high levels. So if hepatoblastoma is another tumor, where if the CT is characteristic and AFP is elevated, one may not have to do a biopsy. So once again, We don't want to do a biopsy in these cases. In Wilms tumor, sometimes we will treat even without a biopsy if the radiological signs are characteristic. Amongst the adolescents, we can have abdominal lymphomas, dysgerminomas in girls, and the mixed germ cell tumors. The tumor marker is a helpful non-invasive test. AFP, beta HCG can be done, LDH, inhibin, all of these are other tests. So these are the others. So importantly, solid mass, most likely to be malignant, organ of origin and age give us a clue on what it is, but don't miss the diagnosis. Don't think it is benign and let us approach, further investigate, ultrasound, CT, these are the investigations. For neuroblastoma, urinary BMA, HVA, for germ cell tumor, alpha fetoprotein, beta HCG. But to remember that the dysgerminomas may have normal tumor markers. Moving on to mediastinal masses, again, this is just pictorially to show you that it is important to know the origin of the mass. And depending whether it's superior, anterior, middle, or posterior mediastinal, we can get a clue what is this tumor. So if we look at the malignant conditions, so there are a host of benign conditions which occur in the mediastinum. So it is important to rule those out. But again, solid masses, malignant would occur usually if it is in the anterior and middle mediastinum would be again with leukemia lymphomas or germ cell tumors. And posterior mediastinum, the two most common, I will say, are neuroblastoma and Ewing sarcoma. In both of these, they may be intraspinal extension of the tumor if they are in the posterior mediastinum. So this is another important clue. So the mediastinal masses may either get detected on a routine X-ray, which was done for some other asymptomatic cases, or symptoms are there due to compression of adjacent structures leading to cough, dyspnea, stridor, dysphagia, engorged neck veins, chest wall veins, fever, etc. Or may even we have seen patients presenting with severe respiratory failure coming in oncologic emergencies. They may be associated, there may be a solid mass, it may be pleural effusion, pericardial involvement, etc. So in mediastinal masses, I'll give you a few case scenarios. 9-year-old presenting with cough, dyspnea, and you can see here this total opacification of the left chest. There is definitely a pleural effusion. We cannot say if there is a solid mass. So for the first approach, again, we try to be minimally invasive. So importantly also to remember that we have to be very careful about sedation of these tumors, especially if the airway is compromised. So CBC and peripheral smear in this child were normal. And a pleural tap was done. It is not so difficult to do a pleural tap. A biopsy is far more difficult, but we have to be careful about the sedation. Also, if we have to give IV fluids, we will avoid IV fluid in the left arm. So we will find a peripheral lymph. So how will we proceed? So we did a pleural tap for this child. There were a lot of lymphoid cells. Then we did a flow cytometry. And on the flow cytometry, there were CD3 positive cells suggestive of T lymphoblastic lymphoma. So we did a cytology on the pleural fluid, and we did a flow cytometry on the same pleural fluid. And by that, we could confirm that it was a T lymphoblastic lymphoma. We did a bone marrow for staging, and the bone marrow was normal. So we could avoid doing a true cut biopsy. Now, if the pleural fluid had been negative for malignant cells, we would have had to do a biopsy from the solid mass if there was one, or do a lymph node biopsy. DD, of course, could be, if there is a solid mass, we don't think that it is a tuberculosis. Otherwise, another cause in older child pleural effusion is tuberculosis. So now this is another scenario. The older child, again, totally opacified left chest. But when you do a blood test, you find that the KFT is deranged, uric acid is high. So this is showing tumor lysis syndrome. This is again a place where we have to be very careful because these patients often have a lot of respiratory compromise, the airway is compromised, and they may suddenly deteriorate. So presence of high uric acid, high urea, it means that there is a tumor burden, there is a tumor lysis, and we should be very careful about being very quick about getting a diagnosis. If there's a large mediastinal mass, pleural effusion, then short history, tumor lysis, I will suggest either we can do a true cut biopsy, or if the CBC is abnormal or showing red flag clues, I will like to do a bone marrow aspirate. So these are the two ways we can reach a diagnosis and understand. This is a big mediastinal mass. This is not benign. This is not tuberculosis. If it was tuberculosis, we will see the lymph nodes in the hilar region. Importantly, careful examination of CBC, good history, peripheral smear is important. If CBC is not diagnostic, then CT scan, and we need either bone marrow or a true cut biopsy immediately. We have to be very careful about sedation. The patient may suddenly crash, suddenly decompensate. So make the child comfortable, stabilize the child before jumping in and doing anything. There is no, everything has to be done expeditiously, but not precipitously. And these patients should not be compromised by putting a cannula in the upper limb. That can worsen the respiratory status. Now I will not go in detail about this one because we already discussed posterior mediastinal mass. Opsoclonus, if present, again, is a clue for neuroblastoma. Lateral X-ray chest is important. It will tell you whether it's a posterior mediastinal mass. And elevated urinary VMA, HVA are other important tests which are non-invasive and give us a clue about the diagnosis. Just to show you a few more pictures on mediastinal mass. Mediastinal masses, so this, the one on the left, this is a child who had a lymphoma diagnosed. And the other one on the right side, this was a Ewing sarcoma of the rib. The rib was eroded, I think the 8th rib, but not showing up very well. And there was a soft tissue mass along with it. We got the diagnosis with a true cut biopsy. So moving on to extremity masses. The extremity masses that are frequently neoplastic are Ewing's and osteosarcoma, seen most likely around the knee and seen in the older child, and usually when the child is growing, attaining increasing height. In the younger children, rhabdomyosarcoma is the most common soft tissue sarcoma. This is the extremity mass that is seen. So how do they present? Usually pain comes first for bone tumors and swelling comes first for soft tissue sarcoma. Fever may or may not be there. Ewing sarcoma may have fever as well. And the plain X-ray of the limb is a good X-ray. AP lateral is very critical. And as you can see here, there is a sclerotic. This is the distal femur. There is a sclerotic lesion. You can also see the periosteal invasion, very subtle here, but if you look carefully, you can see it. And then you can see here the little infiltrates of bone into the soft tissue. So plain X-ray is a first investigation. The next investigation we do, usually if it is abnormal, is an MRI, and the third will be biopsy. For biopsy, I will say not just anybody should do the biopsy, because it has to be done in the correct plane, because this is the era for limb salvage surgery. If you do it through the wrong plane, the child may end up with amputation. CBC is important, as in all cases of childhood cancer, because for metastatic bone disease, they may give us a clue. Usually metastatic bone disease is less common in the adolescent, more common with neuroblastoma in the younger age. So the osteosarcoma and Ewing sarcoma are the two most frequent ones. Osteosarcoma will occur at the extremities of long bones, and the lesion will be sclerotic, mostly maybe lytic. It will have a broad zone of transition. You can see here periosteal elevation, sun ray appearance, and soft tissue involvement as well. Both these X-rays are showing you the femur X-ray is showing more subtle signs, while the gross, very advanced disease is shown in the one where the proximal femur. This is, you can see here, Codman triangle, sunburst appearance. So this is very advanced. You don't want to have a child come picked up at this advanced stage. You want to pick up in an early stage. In Ewing sarcoma, the characteristic is onion peeling of the periosteum. So there is elevation of periosteum and new bone formation, and that is seen very nicely in the left X-ray over here. I want to show you this X-ray. I think all of you can see in the proximal femur here, there is a very well-defined lytic lesion. This was LCH, and I want to tell you the benign lesions have this very sharp demarcation line, while the malignant ones will have a broad zone of transitions. That helps you to differentiate benign from malignant. Now moving on to brain tumors. So headaches. Now children have headaches if the headache is waking them up in the morning. If the headache is associated with morning vomiting, it is recurrent, we need to worry about it. Regression of milestones, seizures, double vision, neurological death, any of these can coexist along with headache and vomiting. We want to be sure that we diagnose correctly our headaches and we don't miss them at all. So I will have 3-4 cases here. 4-year-old boy who is attending nursery, normal growth and developmental milestones, for 2 months complaining of headache, disturbed sleep, sometimes wakes up in the night because of headache, very irritable in the morning. Initial neurological assessment was normal and paracetamol was advised. But now, 2 things we have to see. One is headache in a young child waking up from sleep. This is important. Waking up in the middle of the night with headache, morning vomiting. This is important. Then vomiting soon after waking up. And then no nausea. There is no nausea with this vomiting. So this is another important thing. And then after a few weeks, because the child was, following up with the doctor, but there was no neurological deficit. Then the mother went back. My child is actually walking unsteadily. So a CT scan was done, and that's when the tumor got detected. So persistent vomiting, abnormal balance, abnormal tilt of head, all these are clues that there is something in the CNS. And I think any good pediatrician will be able to pick it up. If with headache, you keep these little subtle signs in your mind. So this is another 16-year-old boy, active in football and swimming, complained of occasional generalized feeling of weakness. And they said, oh no, he has some girlfriend problem and this and that, nothing. And then after 2-3 weeks, it was realized that he was a goalkeeper, that he was not able to keep the goal so well, that he was not able to kick well, he was clumsy, he was uncoordinated. So when the doctor saw this child and he noted this thing, then a neurological examination was done, an LP was done, nothing was abnormal. But ultimately, he developed weight loss, and then he developed DI, and it was further realized that actually he was having a tumor in the pituitary. So even excessive drinking of water, excessive thirst, waking up 3 times in the night to drink water, it was DI, diabetes insipidus, associated with blurring of vision. So these are other subtle clues. So if a child is saying, बहुत प्यास लग रही है, बहुत urine आ रहा है, then ask, is he waking up in the night to drink water? And if there is associated blurring of vision, you can think there is something in the pituitary. So don't ignore these and don't say just that it is because of summer weather. So careful history, thorough neurological examination, they can help us in early diagnosis. And as I have also said, early childhood brain tumor diagnosis is important because when it is diagnosed early, a complete surgical resection is possible and cure is possible then. If surgery is not possible, then cure is unlikely. So eye changes, as you know, retinoplastoma. Now, I think during immunization, we must try to look at the eye of the child. And if there is a white reflex, definitely get this child fundus done. Make sure we are not missing a retinoblastoma. You should know that in retinoblastoma, we not only want to save the life, but also the sight of the child. If we can save the eye, we can save the sight. That is a big reduction in disability for our children. So they are coming to us. These children get diagnosed late, and we don't want to diagnose them late. We want to diagnose them when there's just a loss of the red reflex. So at every immunization visit, before they give the vaccine, please look at the child's eye and make sure that we are not missing leukocoria. So these are the ways in which they may present: leukocoria in 60%, strabismus rubinosis, hyphema, heterochromia, glaucoma, proptosis. So I'm telling you the top 1 and 2, that's when we want to pick up the child. We don't want them to come with so advanced disease that we cannot save the sight or the eye. What are the other eye changes? So we saw retinoplastoma, but there are other eye changes also that we may see, and which can be clues for it being a neoplastic process. So what are these? So proptosis. Now I'm showing you these pictures of quite advanced proptosis, and these are the top photograph, the top image. It is of a child with chloroma, AML with chloroma, but it can also be an NHL patient with deposits in the eye. And if both eyes are involved, we should think it is a systemic condition. So it could be a leukemia, or it could be a lymphoma. They are the most common. If it is unilateral, as you see in the panel below, then you have to see whether it is coming from the eyeball or is it coming from the globe. So retinoblastoma will be from within the eye, but a rhabdomyosarcoma will be from outside the eye, from within the globe, from the muscles in the orbit. Papilledema would be another clue which can tell us what is happening when we look at the fundus. So white spot in eye, new squint, new blindness, proptosis, seek medical attention early, get an ophthal evaluation, follow the child, call them, make sure they don't rest at home, and I will go after 3 weeks or 4 weeks. Let them go urgently. We want to pick it up early. What about scrotal masses or testicular masses? So adolescents and young children both can have these. If we have an adolescent, so anytime scrotal mass translucency should be done. If it's a solid mass most likely is neoplastic. Ultrasound gives us a good clue. What does it tell us? Ultrasound will tell us if it is a fluid or a solid. It will also tell us whether the mass is in the testis or it is a paratesticular mass. And this gives us a clue about the underlying diagnosis. Germ cell tumors, leukemias, lymphomas will be testicular masses, while rhabdomyosarcoma will be a paratesticular mass. It's a scrotal mass, but outside the testis. Very important, please don't do for solid masses a FNAC or a biopsy transscrotally, because then you will seed the scrotum and you will have to do a scrotectomy. We don't want to do a mutilating surgery for these children. If it is a solid mass, we do a high orchid. We do not do a transscrotal biopsy. So once you know it's solid, if you want to further investigate, if it's an adolescent, it's the chance of a germ cell tumor. You can do a tumor marker. You can do a CBC to see if the peripheral smear is normal. You can do a good history examination, make sure there is nothing else, but don't biopsy through the scrotum. So role of pediatrician, as you see, is there in early diagnosis. What do you mean by early diagnosis? By early diagnosis, we mean that the patient will have no increase in morbidity or mortality, and that we will therefore not miss the diagnosis if there are progressive and persistent symptoms, because timely diagnosis is essential for cure. Now, these pictures I'm showing you to tell you that if we have delay, what happens? Delay means low cure rate, it means high toxicity, it means higher cost of treatment. So you can see delay means no limb salvage. Delay means more complications, and we don't want these complications. So just to reinforce, what are the reasons for diagnostic delays? How do we miss that? We miss the diagnosis because it is uncommon. 150 per million children is the incidence. There are no classic telltale symptoms and signs. The cancer symptoms and signs often mimic those of common childhood illnesses and injuries. And socially, psychologically, there is a reluctance to entertain the diagnosis. Delay leads to high complication rate and poor outcome. High index of suspicion will help us to have an early diagnosis and excellent outcome. So just to put it all, summarize everything together, recurrent fever with bone pains could be due to leukemia, neuroblastoma, Ewing sarcoma. Neck nodes not responding to anti-tubercular or antibiotics could be due to leukemia or lymphoma. Pallor, fatigue, weight loss again could be because of hematological malignancies. Mass in abdomen could be because of a Wilms, neuroblastoma, hepatoblastoma in young children, and germ cell and lymphoma in older children. White lesion in eye could be due to retinoplastoma. Back pain, urinary and bladder symptoms could be due to abdominal masses. Chronic ear discharge could be because of LCH or external ear rhabdomyosarcoma. Sarcoma. Extremity masses could be due to osteosarcoma, Ewing sarcoma, or rhabdo. Orbital masses could well be due to lymphomas, leukemias, or rhabdomyosarcoma, and scrotal masses, as we saw, because of rhabdomyosarcomas, germ cell tumors, or lymphomas. So early diagnosis is possible with vigilance and high index of suspicion. The common signs and symptoms, as we saw, could be fever, headache, persistent lymph nodes, anemia, bleeding, hepatosplenomegaly, silent abdominal muscle, gonadal mass, changes in gait, balance, personality, and white-eyed reflex. Uncommon signs and symptoms could be unexplained weight loss, constitutional symptoms, bone pains, arthralgias, arthritis, unexplained by any reason, and paraneoplastic symptoms like hypercalcemia or opsomyoclonus. So what are the warning signs? People have made mnemonics, and if you like, you can remember any of these. If you see the mnemonic, the first alphabet is children, C for continued unexplained weight loss, H for headaches with vomiting, I for increased swelling or pain in joints accompanied by limping, L for lump in abdomen, neck, or elsewhere, D for development of a white appearance of the pupil or visual problems, R for recurrent fever not caused by infections, E for excessive bruising, and N for noticeable pallor or tiredness. So to summarize, cancer in children is clinically heterogeneous disease with signs and symptoms mimicking common pediatric conditions. Early recognition and rapid diagnosis are essential to improve survival. Pediatricians have an important role and should be alert to malignant disorders having a high index of suspicion in DDs because childhood cancer is curable. Thank you very much. Any questions? I should be happy to take.
Thank you, ma'am, for a wonderful presentation. We have some questions. One is just related to the delay also in the treatment. How vital is the role of a pathologist in early diagnosis of any childhood cancer, along with physician? Mostly dilemma of blood picture leads to late diagnosis. How can we avoid this for early diagnosis? Please give your suggestions.
So shall I stop slide share or shall I continue?
Ma'am, please stop slide share.
Okay. So a very important question. And for leukemia especially, the role of pathologist is vital. Therefore, I say that, when a child is actually coming to, the child will not go to the pathologist, the child will come to the pediatrician. So when they come to you and you clinically suspect, you should call the pathologist and say, I'm suspecting this fever is not responding. This child has got lymph nodes and hepatosplenomegaly. Can you please see the smear again and tell me if there are any clues whether it could be a leukemia or is it a viral? Because they can easily tell. It is very, very critical. Same way, the lymph node biopsy and the lymph node FNAC. Pathologist has a very important role because often the FNAC is done by the pathologist. So I will suggest to all the clinicians that please avoid doing FNAC. Don't recommend the FNAC at all. Use your clinical judgment. If you feel this is a pathological node, then ask the CBC. If the CBC is perfectly normal, then get the lymph node biopsy. So role of pathologist is very important. You have rightly said. I can see one question of why is MRI not a better investigation than CT scan in investigating the mediastinal mass? Dr. Ajay, I think you are on mute.
Yes, ma'am. Ma'am, why MRI is not better than the CT scan for mediastinal?
So I will do X-ray chest first. Then I will do CT chest. And why is MRI not better? Because one is to make a child with a chest mass lie down for 40 minutes is going to be very difficult. But the CT scan will hardly take a minute to do. So I just want to know, is it a solid mass? I want to know, is it a pleural fluid? Can I do a biopsy? And I will have to do a CT guided biopsy if I have to do a solid mass biopsy. I cannot do MRI guided biopsy. This is going to be very challenging. You can't take the needle inside the MRI room. So, however, if there is a mediastinal mass and I want to operate the patient, then I will probably go for MRI. But when I want to diagnose something, then a CT is good enough. It is quick and it gives us whatever I need, the information. So I think there is a question by Shari, 14-year-old, influenza positive with petechiae and severe thrombocytopenia, history of weight loss, no anemia, lymph node or organomegaly, no atypical cells. So you have to see whether you are thinking all of this is because of influenza, or is it because of dengue, or is it because of COVID? So pure influenza, I will not see petechiae and thrombocytopenia unless I'm thinking this is ITP. But I will want to know better, a little bit more about the child. Is there any hepatosplenomegaly? No, you said, right? So I will actually go for bone marrow aspiration. If the peripheral smear is normal, even then, I want to be sure that I'm not missing a diagnosis of leukemia, but also if there is an HLH happening, I may miss it.
And there's another question by Dr. Pradeep. We had 10-year-old child with cervical lymphadenopathy, ESR 120, lymphocytosis, presented with fever for 1 month. Weight loss, ultrasound neck shows caseating necrosis, FNAC negative for AAB, 1 to 9 mm. For this child, needed lymph node biopsy, or we can start ATT. I think this is a little unrelated, but
I think we can ask Dr. Ajay, will you use ATT? Because it is a pediatrician who will decide. I will not decide. So Dr. Ajay, is this, I think caseation necrosis is there. Only thing is MON2 is only 9 millimeter.
Ma'am, it's okay, but if there is a caseation necrosis and it is all the features suggestive of ATT, then one can go for the ATT.
Yes, I also agree. I agree.
And, there is one more question, ma'am.
Yes.
If you suspect right history and ask for peripheral smear examination, in a child with increased cry at night, how to differentiate night terror from ICSOL? When to do imaging?
I think we have to do good history and examination first. Child is having headache or his child is crying. So we have to differentiate. Headache is there and the headache is making child get up and cry. I want to do a little more. I want to see, is there morning vomiting? I want to see what is the duration of illness, and I want to see what is the age of the child. I will not jump and do brain imaging for all children crying in the night. There are many causes of crying in the night.
And there's another question by Dr. Sanket. We had a patient of 9 months with severe anemia with hemoglobin 2.2, low WBC and febrile neutropenia with ANC being 340 cells. Patient was having normal platelets. She was having motor delay, was on milk-based diet with bottle. Patient was given 2 aliquots of PRBC, but had low HB with HB 6.8, low NC count of 740 cells. We did a bone marrow aspiration, showed hypoplasia with myelodysplasia. So we had to send fish for MDS, but it was normal. Did we miss something? And what should have been approached to this patient?
So can I just ask for the age? I'm not seeing it on the chat box.
9 months.
Achha, it's in the chat box. Where is the question?
Question answer, ma'am. It's in the answered one.
Oh, okay. So I'm not able to see. That's why.
Okay.
9 months old with pancytopenia, low hemoglobin, low ANC, and low platelet. Correct?
No, platelet was normal.
Platelet is normal.
Okay. And when they did the bone marrow aspiration and biopsy, they found there is myelodysplastic syndrome. And you are saying that the sequencing did not show any
fish was negative
MDS
for MDS
related genetic abnormality, correct?
Yes.
I think MDS is diagnosed on morphology of the bone marrow, and not all the patients will have any genetic abnormality. So I think that you have.
I think we can ask him, Dr. Sanket, to please share the detailed reports with you, so
Sure.
that we can.
Sure. I think that if there is MDS, then morphologically that diagnosis is established.
Dr. Sanket can ask directly. He has been unable to speak.
Okay.
Dr. Sanket, yeah.
Good morning, ma'am.
Good morning.
Ma'am, the same patient, actually, the patient has been discharged again, medical advice. Then when we did the bone marrow aspiration, biopsy was not done. In that, the pathologist reported features suggestive of myelodysplasia. And then when we did the FISH for the cytogenetics, it was negative in all the deletions and mutations. And now we don't have the patient, but the last hemoglobin, which was there pre-discharge, was 6.5. And the ANC count was around 740 cells, as far as I remember, ma'am. So what should we do now for this patient? Like anything else?
So FISH is not 100% able to capture all the patients who are having disorders. So I think if you share with me all the reports,
okay,
ma'am. This child will need more detailed workup. It is not obviously a straightforward case of leukemia, but yes, whether it is MDS or not, that also we have to establish. And maybe the bone marrow aspiration slide can be brought over. We can review them for you. And we can take little more about the details of the history, any drug intake in the mother.
No, ma'am, the child was non-syndromic and there was no history of any previous admission. Or the diet was maximum on buffalo milk and cow's milk with bottle feeding. Complementary feeding was not started properly. The child was immunized till 14 weeks of age. After that, the child was not given any immunization.
So, this congenital dyserythropoietic anemia is also there. So I think we need to, the MDS is very rare in a 9-month-old. So I think we should look at the slide again. And if required, we can repeat aspirate and biopsy. And just look at, maybe we can look at the smear for you.
Okay, ma'am. How should I send you the reports, ma'am?
Please send it to me. I will share with madam.
Okay, sir. Okay, sir. Okay, sir.
Dr. Vipul, can you ask the rest of the questions?
Thank you, sir. Thank you, ma'am.
Okay.
Sure, boss.
2 months old.
Yeah. Can we suspect Kikuchi Fujimoto in cervical lymphadenopathy?
It is, yes, it can be with the biopsy. Yes.
Okay.
Biopsy, yes. Not by FNAC.
A 2-month-old FCH presentation with pancytopenia with past history of fever and URI 10 days back. Bone marrow suggestive of refractory cytopenia of childhood. So how to proceed further?
What is FCH? What is FCH?
I'll just enable her.
2-month-old.
Dr. Malika, you have been unable to speak. You want to speak something? HB is 5.5, WBC is 3,500, platelets 23,000.
So I will first of all, in a 2-month-old, think of a congenital viral infection and proceed with that. You should do the full workup. I'm sure you have done. And if nothing is coming up, child is well. Is the child well or is he sick? Fever. But is the child?
Child is well, madam. Child is well, madam.
Okay. So you don't think it is something viral, or did the mother take some drugs?
No, madam. The child is on breastfeeds, madam. Now the child is 2 months old. Actually, the child was presented with fever for the past 2 days. So we have done the workup and the CBC showed pancytopenia. So we sent for the bone marrow, ma'am. It showed this report.
This is bone marrow report?
Yes, madam. Bone marrow.
What is FCH?
Female child, madam. Female child.
This is, you are saying HB is 5. Acha.
Yes, madam. Presentation, at the time of presentation, this was the CBP, madam. And they showed in the WBC count, the lymphocyte was predominant, like 80% was lymphocytes.
80%. Is the child getting better?
Actually, the counts were still decreasing, madam. Clinically, the child was stable, but the counts were decreasing.
Okay. So as you know, it is a subgroup of myelodysplastic syndrome. It
Okay,
has been
ma'am.
added to the WHO classification in 2008.
Okay,
And
ma'am.
basically, we have to follow this child till the child is a little bit bigger and see how the child thrives. Because, you know, MDS is one very, what shall I say, difficult area. It is rare. I think the previous child also, they have said MDS. MDS does not have any good treatment. And if it is truly MDS, then the only therapy is a bone marrow transplant.
Okay, ma'am.
So actually, we should follow this child and see if we can keep the child free of infections. Because WBC is 3500. If infection is not a problem, we should just follow the child and see. Sometimes these changes can also occur post-viral infection or post-sepsis or post-infection. So the most important, keep child on close, good follow-up, good nutrition, proper immunization. And as the child goes, serially monitor the hemogram.
Okay.
And if it recovers, great. If it doesn't recover, then we should try to search for a bone marrow transplant donor. And once child is a little bit older, we can think of doing a bone marrow transplant.
Okay.
That
Okay,
is
ma'am.
the curative treatment for MDS in young children.
Okay, ma'am. Thank you, ma'am.
Dr. Jolly, you are unable to speak. You want to ask your question directly?
10-year-old with generalized lymph nodes.
For more than 1 year, now biopsy diagnosis is Castleman diagnosis, a disease with positive EBV and very high IgG levels too, ESR 120, but other CBC platelet normal. Now complaint is patient is having on and off high fever and cough, which are more than 3-4 months. TB workup done all negative. What should be the further steps? Yeah, Dr. Jolly, please.
Good morning, sir and madam. So yeah, that patient 10 years old, actually previously she was showing as a OPD base in our hospital. And now actually it is more than 1.5 years as per the history. And when I got the case, now it's almost like 4 months. We have been working up, and already she had done with a biopsy report to us and giving that diagnosis of Castleman disease. So we got second and collected the previous block only. Then we got it done. The second biopsy, the same report had come. And the main problem is as we have come to know that the Castleman disease, so only that supportive, so nothing to be done. Counseling has been done to the parents, but they are more worried. The child is repeatedly, almost every day, she is having high-grade fever. She used to get fever, and there is one cough, and now the duration is so long, so I'm also worried. So I have worked up for the look for the lymphoma panel also, which also has come out to be negative for lymphoma. So what to do in this patient? Actually, I am also now like more concerned for the parents also. So they are they got admitted, they are in the hospital now. So we are just trying to rule out if there is associated TB also. So TB workup is also coming out negative. Recent abdominal CT scan with CT thorax also has been done. So there are few lymph nodes in the mediastinum, but abdominal lymphadenopathy is there. But they are also not given as suggestive of tuberculosis. Just mentioned that abdominal lymphadenopathy is there. So is this lymphadenopathy as a part of your previous disease?
Dr. Jolly, I think you are having very challenging case. And
Yes,
you're doing a great job. So as you know, it's not a clonal disorder.
Yes,
and if it is unicentric Castleman disease, it is easy to manage because you can remove surgically the lymph node. But if it is disseminated disease and having the symptoms like you are describing, then immunotherapy can be tried. So
okay.
Isn't it?
I'm thinking of that, ma'am.
Yeah.
It's that's why I have admitted the patient,
Correct.
but still wanted.
But you are right that viral antiviral drugs are also used. So I think that by clinical judgment and other things, you can involve your infectious disease specialist also to make sure that you are not missing TB. That naturally, when you will do immunotherapy, then any infection can flare up because you are Because Castleman disease is a disease in which the hyperactive lymphoproliferative disorder is there.
Yes, yeah.
Right. So I think you're doing a good job. You can consider immunotherapy, but involve one infectious disease doctor with you, so he can share the responsibility and you can have shared decision making, because not everything is in black and white in these challenging cases.
So she has a very high IgG level also, ma'am, and EB virus is positive.
So you can EBV PCR is positive or IgG IgM?
IgG is positive and EBV done, that is just for diagnosis, which that has come positive.
So IgG tells you that it is an old disease or old
Yes.
infection, isn't it?
Yeah, all infection, yes.
Yeah.
Because these things are not, we cannot do in our hospital. We have to send it to outside. So it is also costly, patient also not affordable. Somehow we have managed up to this level. What kind of immunotherapy, ma'am? Can you just?
So, people have tried steroids, they have tried chemo, and they have tried immuno. But I will say in immuno, there is this rituximab people have tried.
Okay.
Because there is silutuximab and rituximab, but I think rituximab is more available in India. So,
yes.
If you like, you can send your summary, and we can see if I can.
Okay, definitely. I will send all the biopsy reports and all the cases with the patient
I can suggest you.
pictures.
No,
yeah. Thank you very much.
Dr. Shari, you want to ask? Yeah, please go ahead.
Yes, sir. Ma'am, I had a 4-year-old girl. She apparently presented first time to me 4 months back with a viral fever, pharyngitis, and reactive cervical lymph node enlargement, significant lymph node enlargement, which on follow-up around 4 weeks, it had come down in size, ma'am. Peripheral smear was also normal. There was mild nutritional anemia, microcytic hypochromic anemia. But this child, after 2 months, again, she presented with fever and the same lymph node, ma'am, significantly enlarged. And other cervical lymph nodes were also enlarged. USG neck showed that the lymph nodes were necrotic.
So how large is the largest lymph node?
Ma'am, would be around 5 centimeters, ma'am.
So can we do a biopsy?
Ma'am, apparently this was in the submandibular region of the neck, ma'am. So due to the nerve involvement, we haven't done a biopsy. FNAC showed caseation necrosis, ma'am, but the TB workup was negative.
So once again, you have to use a little bit of clinical judgment. You can't do you are not able to do lymph node biopsy, but there is caseation. So I think there is difference between necrosis and caseation. If there is caseation and your clinical picture is supporting tuberculosis, I think you can go for TB treatment with a close follow-up. If the child responds, you're good. But if the node is increasing in size, I suggest to do a lymph node biopsy, especially because your other TB workup is negative.
Thank you, ma'am.
This is suggestive that there is a malignancy, but caseation is not suggestive of malignancy.
Okay,
so
ma'am.
we can talk with the pathologist and just try to clarify it.
Okay, ma'am.
Well, most of the recurrent abdominal pain cases with ultrasound shows lymphadenopathy. When to get worried that this is a malignancy?
So I say that we should not do ultrasound for any pain abdomen because patient attendant is persisting to do it. These small mesenteric nodes are often present in patients with any GI infection. So 1 centimeter node, 1.2 centimeter node. If the child is otherwise well, we will disregard. No lymphoma will present with 1 centimeter nodes in the abdomen. Usually it will be a big nodal mass by the time they cause pain and other things. So usually the pain is due to some GI infection. Many people come with the ultrasound report, 1.2 centimeters, but they are just present routinely in these children. They are not.
Is there any minimum finding that this much size, this number of nodes, this kind of section? Nothing.
There is no evidence for this because I think it is mostly seen in LMIC countries and there is no data. But I think if you will do for 10 children of that young age group, 5-year-old, 6-year-old, I think everybody will have small mesenteric nodes.
Perfect.
So I think we can take history and just see if we didn't do an ultrasound, how was it? But if there's a 5 centimeter mass, you really know it's something you have to worry about. 3 centimeter mass, 4 centimeter mass, definitely. But I think 1 to 2 centimeter, multiple small, nothing else.
So we can take 3 centimeter as a cutoff as an alarming sign?
No, I cannot give you that.
Okay, perfect. So one should not be jumping onto things like this.
Yeah.
Dr. Vikas, you are allowed to speak. You want to speak something? Dr. Vikas? I think that was the last question. Dr. Jagdish, can we have your comments?
Excellent, sir.
Yeah, Dr.
Hello?
Vikas. Yes, Dr. Vikas.
Sir, tubercular lymphadenitis and Kikuchi Fujimoto. So दोनों को differentiate कैसे करेंगे सर? दोनों का presentation एक जैसा होता है सर लगभग. सर सुन पा रहे?
हाँ, we can. Ma'am.
Kikuchi और क्या? Kikuchi और?
Sir, tubercular lymphadenitis.
ये तो पैथोलॉजी से ही निकालेंगे ना कि पैथोलॉजिस्ट से पूछो ये सवाल मैं नहीं बता सकती मैं तो क्लिनिशियन हूं
I think the biopsy will be able to differentiate between the two. There's hardly any similarity between the two on biopsy on histology. Clinically that's fine, it is the cervical lymph node enlargement, but the biopsy histology would be characteristic and it should be differentiated by the patient.
Okay, thank you, sir. Thank you, ma'am.
FNAC ना करें. I will say FNAC avoid करिए.
जी मैम.
Dr. Jagdish, your comments?
Yeah, I think most of the things very lucidly Dr. Gauri has pointed out regarding the topic of not to missing the cancer cases, and a very good discussion has taken place. Nothing else to add. My compliments to Dr. Gauri for this.
Thank you, sir, for the invitation and the opportunity.
Thank you. Yeah.
Dr. Kamalji, Dr. Payali, you want to ask something?
No, sir. It was a very comprehensive talk, ma'am. Thank you.
Thank you, Piali.
Thank you, Dr. Gauri, for such a wonderful session, and I think it was enlightening. I was surprised that there were so many questions because you almost took everything that a clinician sees in his practice and where he should suspect cancer as such. And we have this session recorded on YouTube. People will, I'm sure, will see this again and again to find small things which you have covered over a period of 1.5 hours. It was very informative. We had more than 300 participants today also who joined us and listened to this. Thank you, ma'am, very much from our side for sparing time and enlightening on this topic. Thank you very much.
Thank you, Dr. Ajay, Dr. Vipul, and also Delhi IAP for and all the people who have thought about this certificate course, because I think it's very critical and important. So thank you for choosing this topic and for involving me and for organizing this fantastic program, certificate course.
Thank you. Thank you, ma'am.